and we are going to go ahead and get started. Welcome, everybody. My name is Elizabeth Aloni. I'm with Schneps Media, and Schneps Media is the largest local media company in the New York metro area. We publish over 70 newspapers, magazines, websites, webinars, podcasts, and events, and do so throughout Queens, Brooklyn, the Bronx, Manhattan, Westchester, Long Island, and Philadelphia. Today, we're thrilled to bring you top experts to talk about colorectal cancer, screening, treatment, and risk reduction. These four doctors are going to demystify colorectal cancer, discuss why screening is important, provide warning signs, help you understand who should be screened and when, help you understand the current treatments available, and how to minimize risk of recurrence after a colorectal cancer diagnosis. So I am going to introduce you to each one of our doctors today. First, I'd like to introduce you to Dr. Ellen Gutkin. She is a board-certified gastroenterologist practicing at NewYork-Presbyterian Medical Group in Queens. She received her medical degree from Philadelphia College of Osteopathic Medicine, completed her residency in internal medicine at NewYork-Presbyterian Queens, and her fellowship in gastroenterology at NewYork-Presbyterian Queens as well. She's an attending gastroenterologist at NewYork-Presbyterian Queens and assistant professor at Weill Cornell Medical College, Cornell University. Welcome, Dr. Gutkin. Next, I'd like to introduce you to Dr. Jini Hyun. She is a board-certified medical oncologist practicing at NewYork-Presbyterian Medical Group, Queens, and assistant professor of clinical medicine, Weill Cornell Medicine. She completed her internal medicine residency and served as a chief resident at NewYork-Presbyterian Queens, and her fellowship at SUNY Downstate School of Medicine. Welcome, Dr. Hunn. Next, Dr. Roger Patron is a board-certified surgeon specializing in colon and rectal surgery. He received his medical degree from Antioch University in Mexico City and was a research fellow at Yale University focused on bowel transplantation. Dr. Patron completed his general surgery residency at Yale and NHH and colorectal surgery fellowship at Indiana University. He's now an assistant professor in clinical surgery, colon and rectal surgery for Weill Cornell Medicine. Welcome, Dr. Patron.
Thank you very much.
And finally, I'd like to introduce you to Dr. Christopher Foglia. He is a board-certified surgeon specializing in colon and rectal surgery. He received his medical degree from SUNY Stony Brook School of Medicine, completed his residency in general surgery at Beth Israel Deaconess Medical Center, Harvard University, and completed his fellowship in colon and rectal surgery, New York Presbyterian Queens. He's chief section of colorectal surgery, New York Presbyterian Queens, assistant professor of clinical surgery, Weill Cornell Medicine, and program director, general surgery residency program. Welcome, Dr. Foglia.
Yeah, so wear a lot of hats. Thank you, Elizabeth.
We are, I read these bios and I'm blown away. We really are so lucky to have these experts with us today. And I'm really grateful that you've all made the time to be here. So I want to get started speaking with Dr. Gutkin. Dr. Gutkin, why is screening important? And in addition to why is it important, throughout this pandemic, is it safe to be screened? I know a lot of people are concerned about that.
Well, thank you, Elizabeth. That's an excellent question. So colorectal cancer is very important to screen for because it's actually one of the cancers that we can prevent by screening. Colorectal cancer stems from polyps. Polyps are growths in the colon. By screening and doing colonoscopy or certain procedures that we will talk about in this webinar, we can find those polyps and remove the polyps. And to your question of, is it safe to screen in COVID? It is safe to screen in COVID. In our endoscopy suite, we have our patients tested for COVID prior to coming in for procedures. So it is safe for everyone.
That's important to know because I think, we don't want to let these screenings go by out of fear. It's an important thing to make sure you're taking care of your health, no matter what the situation is. So who should be screened? You hear maybe you should start at 45 or at age 50. Who should be screened for colorectal cancer?
So the average age where screening begins was 50 for a long time. Lately, there have been a lot of societies that have recommended screening to start at 45. The American Cancer Society, the U.S. Preventative Task Force, the American College of Gastroenterology just published their recent guidelines. So 45 is now the suggested screening time to start. And I think it also is important to bring awareness to patients that may be younger that may not have thought about screening.
So would you recommend for people who are younger in terms of screening, should they be looking for early warning signs? Is that something that's helpful if you're younger, or really at any age? Could you share with us some of those things that are important to look out for?
Absolutely. So screening means that there is absolutely nothing wrong and an individual fits into an age-related criteria. If patients start to have symptoms such as any bleeding, whether it's red blood or dark stool, or pain in the abdomen, rectal pain, any weight loss, any change in bowel habits, thinner stools, more diarrhea, more constipation, things that don't seem to really resolve in a few days, those things should be addressed with their physician. That becomes more of a diagnostic than a procedure to examine the symptoms. So also, I think it's important to talk about the topic of colon cancer with younger patients, because sometimes people equate, even though they have symptoms, their age with screening. So a younger patient can have symptoms but think, oh, well, I can't get screened because I don't fit the age criteria. So it's important to know that screening means no symptoms whatsoever, just age-related recommendations. Again, our societies have moved up the recommendation to 45 as a suggestion. But if there are any symptoms whatsoever, those symptoms are then not related to screening, and it becomes a diagnostic test. And patients, even though they are younger, should not be shy about talking to their doctors. We've unfortunately had cases of colon cancers diagnosed in patients in their 20s and 30s and 40s where, you wouldn't expect something like that to happen, and patients have symptoms but thought, oh, well, maybe it's just hemorrhoids and, it'll go away. So just very important, don't be shy, talk to your doctors and they will help guide you as to what the next best step is for the workup.
That's such an important point, because it's not like there's something magical about the age of 45. It's based on obviously information, but there's nothing more important than listening to your body and going to a doctor if you see anything that's not as it normally is. So that's a diagnostic. So kind of jumping back a little bit to screening, what options exist for colorectal cancer screening currently?
So currently there are, and the American College of Gastroenterology likes to break it up into one-step testing and two-step testing, which means that if there's a test that becomes positive, you can go to the next test. But to clarify, there are stool-based tests and there are visual tests. The stool-based tests include the FIT test, which is the fecal immunochemical test, which is more sensitive for human hemoglobin than what we previously had in the guaiac testing. And so it's a stool card, so it's easy enough to do. And the other stool test would be the Cologuard test, which is a stool test, but tests for the hemoglobin and DNA with different mutations. Those are the stool tests. If a stool test is done and it is positive, then you would need the step 2, which would be the visual test. So the colonoscopy. So the colonoscopy is a camera test, and we are looking throughout the colon. We are looking left to the right side. The purpose is to look for growths, polyps, as we call them, remove them if we are able to, or should something be very large, we then can take biopsies so that we can determine what the next best step would be for the patient. So colonoscopy is a visual test. There's a camera that's looking through the bowel via the gastroenterologist, the physician that's doing the test. And so we're able to see sort of immediately what is going on within the colon. The other visual test that is used but not recommended first line is a CT colonography. So a CT colonography is what we call a virtual colonoscopy. It's a CAT scan. It's a CAT scan with a bowel preparation. So the patient would have to drink a bowel preparation to cleanse the colon, also drink some contrast. And they go into the CAT scan machine, and the radiologist is able to see, are there polyps or growths within the colon? If those are identified, that leads us back to the colonoscopy for biopsies and removal.
So when would the virtual colonoscopy be required? Is that around an age? Is it based on particular symptoms? Why would someone be recommended that type of screening?
So the best test is the one that the patient is willing to undergo. And that's why it's also important to talk to your doctor and know about all of the options that exist. Sometimes patients may be, with a preference of doing something that's a little bit less invasive, like the CT colonography. Sometimes for the colonoscopy, we use sedation and anesthesia. Sometimes there are multiple other medical problems and history that a patient has that may not make them the best candidate for anesthesia, and sort of lots of things have to be accommodated for. And it would be helpful to know, is there something that we're going after? Do we really need to do a test with anesthesia sedation? Sometimes patients are on blood thinners nowadays for multiple different conditions. Depending on how safe it is to stop the blood thinner, sometimes the patient may choose to do something like a CT colonography to know, is there something there that we really need to stop the blood thinner for? This is all sort of, risk discussion, depending on all of the medical problems that a patient may have. Is it the first test that we recommend for screening? It's not. But it is very helpful in sort of our whole armamentarium of tools that we have to work with each individual patient and account for their preferences and their medical problems and, all of the things that come into this decision.
That's good to know. So there's a lot of options, but it's going to be individualized based on the patient. And I just want to say, I got a colonoscopy and it was easy breezy, and no one should be afraid to do it. And actually I enjoyed my rest. So I highly recommend it. No one should be afraid to go ahead and do that if you and your doctor feel that it's the right thing to do. So what should someone expect after a screening? How does one understand test results and next steps?
Well, so after the procedure, your doctor will speak to you about the results of things that were seen that day. You will also usually leave with a report that your doctor will write about what was seen that day. If there were no polyps seen, then that's good. That's a negative exam. If there were polyps seen, removed, biopsied, then you would follow up with your doctor to go over those biopsies in the office.
Very good. So when should a patient come back for screening? How often should this screening occur?
So the screening or surveillance, I guess, whichever way you want to call it, depending on what was found, depends on what was found. So are there polyps? How many polyps are there? What type of polyps come back on the biopsies? And there are a few different ones. Polyps range from hyperplastic, which is normal tissue, to tubular adenomas, tubulovillus, villus, different types of descriptions that the pathologist will give. So depending on how many polyps, how large the polyps were, the interval for screening will be determined. For a completely normal negative colonoscopy, all of the society task forces recommend 10 years for screening. And then everything else varies in between depending on what was found and what the histology showed. So it could be 5 years, it could be 3, it could be 1, really dependent on what was seen.
So for a normal test, it's recommended 10 years, unless, of course, in between that time, you have some symptoms.
Correct. Correct. It's important to have people know that symptoms does not equate a screening test. So never be shy to talk to your doctor about symptoms, and don't think that you have to wait for the quote unquote screening test for a certain age, because symptoms that you may have. So always talk about symptoms.
I think that's really an important message, that you're sharing is if you have symptoms, go see your doctor, forget about how old you are, focus on that first. Don't let the pandemic stop you from taking care of your health.
Right.
You can follow the safety measures that are in place and make sure that you're listening to your body and you're talking to your doctor, and not to be embarrassed. This is something can be, as you said, can be treated or can be found early. Is that what we started off saying, right?
Correct. Yep, absolutely. So if we find polyps and remove them early, then we don't have to worry about, having the colon cancer. And then this is why we also do surveillance, because if we found polyps once, we want to make sure you don't grow more polyps again. So yes, and in terms of just, sort of overall mortality, it's number 3 in terms of the cancer-related mortality. We can prevent this, so the colonoscopy, the FIT testing, all those things, talk to your doctor. It's very important. It's also important to talk to your family, because sometimes there is a family history. If there's a family history of colon cancers or colon polyps, those patients need to be screened earlier. We sort of always think about family members that are diagnosed less than age 60. If there's a family member diagnosed less than age 60, that patient needs to be screened at age 40 or 10 years before their first degree relative was diagnosed. And not only is it important to know, does my family member have colon cancer, but it's also important to know, does my family member have advanced types of polyps? So like adenomas, tubular adenomas, tubulovillus adenomas. So it's an important conversation to have in the family, because then sort of, where you should go with your screening.
That's important. So both polyps and cancer can be hereditary. And so the more you know about your history, the more prepared that your doctor can be to make sure that you're screened early enough to prevent cancer.
Absolutely.
Fantastic. Thank you so much. This information has been really helpful to me, I know, and to our attendees. So thank you so much for that. And please, if you have any questions for Dr. Gutkin, feel free to ask them in the chat. If you've already asked questions, we will get to them, I do promise you. So I wanted to move on if a diagnosis means that surgery becomes needed. And I wanted to ask Dr. Patron and Dr. Foglia, what typically leads to the need for surgery?
Right, so that's a very good question. And oftentimes it's the diagnosis is they saw something in the colonoscopy for screening, and they took a biopsy and it comes back as, say, a cancer. Or one of the other different types of results that Dr. Gutkin was mentioning, perhaps, is a type of polyp, but perhaps that polyp is too big to be removed through colonoscopy. And so this is when surgery becomes involved. And we can sort of break it down to what happens before the surgery, the day of surgery, and after surgery. So before the surgery, you'll come to the office and we'll make a physical exam, kind of do a head to toe exam. This will usually be followed by preoperative blood work and some imaging. It's important to determine that if the diagnosis of a cancer was made, that this cancer has not spread elsewhere in the body. So we'll typically follow with a CAT scan of the chest, the abdomen, and the pelvis. And in distinct cases where the suspicion is for some lesion in the rectum, then perhaps an MRI or a rectal ultrasound will also be performed. This will allow us to determine or predetermine the stage, which will kind of guide us as to what specific type of surgery we need to do. It's important to know that in preparation for surgery, you'll also have to have a bowel prep very similar to the one that you'll have for your colonoscopy. And this is important because we want to make sure that the stool is the colon is completely empty of stool, so that's easier for us as surgeons to manipulate and to resect and put back together. We also will anticipate, now we have something called ERAS, which stands for Enhanced Recovery After Surgery. It's a specific bundle of interventions that we do before, during, and after the surgery to ensure that the patient has a swift recovery. And the studies have shown that patients can return to their baseline function much more quicker, makes the whole operative experience much better and shorter.
Wow. So what, there's actually things you can do during surgery that help after surgery heal or feel better?
That is correct. And I'll turn it to Dr. Foglia because he has more information on that.
Yeah, so I mean, there's things that we do before surgery and after surgery. It's kind of a whole bundle to get people ready, not just ready for their surgery, but ready for their recovery as well. And that goes from everything from education to medications that we give before surgery, to techniques that we do during surgery. And then the postoperative care, how to get people better quicker. Kind of the old-fashioned way of doing surgery was opening somebody up from top to bottom and going in, getting our hands in, and taking whatever needed to be out that way. We do things a lot less invasive now, and all of these things without compromising the care of the patient from a cancer standpoint, but with the benefit of having less impact on them kind of overall.
Is this something that you should discuss with your doctor ahead of time? Or is this, pretty much, I mean, obviously at NewYork-Presbyterian Queens, it sounds like it's standard operating procedure.
Yeah, I think it's
something you should bring up with your doctor.
Yeah, I mean, I think, any patient who's having colon surgery should talk about, either to their referring provider, their primary care doctor, their GI, what's going to happen, with surgery, and hopefully they know a little bit, but you send it to the right guy or girl, and they'll be able to instruct the patient on all these things and let them know what's going on. Obviously, as you implied, this is kind of routine for us. It's we have a lot of systems in place that allows us to follow certain protocols so that everyone gets a baseline standard treatment of what they're supposed to get, and there's nothing missed. Obviously, for patients, every patient is an individual, so we have to tailor things for each individual. But we know that using certain techniques and certain protocols, it helps to accelerate recovery.
That's fantastic to know, because I'm sure that's one of people's major concerns. So what types of procedures so now that we found a wonderful surgeon, all of these things are being done to be able to allow the patient to heal as best as possible. What are some of the procedures that are done during surgery?
Right. So I think it all boils down to a couple of things. One is how advanced is or what are we dealing with? And it boils down to the location. So if we're dealing with something that's caught very early on with colonoscopy, there's certain colonoscopic techniques. One of them called endoscopic mucosal resection, where if the cancer or the lesion or the suspicious tumor is not invading too far in through the colon, it could be resected with colonoscopy. Now, if this is a lesion that is lower in the rectum, we can do something called transanal minimally invasive surgery. And this is where we use the robot to put a port through the patient's anus and resect the tumor completely through the anus. That means no visible scars, and it's pretty quick recovery. Again, these type of procedures are reserved for early type of cancers, but it is possible. And beyond that, yeah. Beyond that, we have laparoscopic surgery, which is minimally invasive surgery. We look through a camera. We make incisions that are about 1 centimeter to 5 millimeters to 1 centimeter in size. And we do everything through instruments that are about the size of a regular pen. That way, looking through a screen and manipulating and dividing the bowel and the blood vessels, we can ensure that we take the whole area that is in question and put it back together with, again, minimal scarring, which translates to better pain control and quicker recovery. We can also use the robot in the same instance as a minimally invasive adjunct to make our job a little bit easier with 3D visualization of the operative field. It's rare nowadays that we have to resort to what Dr. Foglia was mentioning, which is the old open, going down the middle and getting our hands in there. Fortunately, we can do most of the cases now minimally invasive. And that will allow us to get the not only the tumor, but the whole blood supply and the lymph nodes with them. So we're like Dr. Foglia said, we're not compromising the cancer operation. We're doing what it needs to be done. We're taking everything that needs to come out with that.
These procedures, I can understand how they make healing a much easier process. I'm sorry, Dr. Foglia, were you just going to say something?
Just to clarify, because we talk about robotic surgery a lot, and it's something that we do quite often here at the hospital. And I think a lot of patients hear robotic surgery, they think we're going to kind of put them under anesthesia, push a button, and the robot's going to take out their cancer. And that's not quite yet.
I wish it could be that.
You still need a surgeon to participate. So how it is it's really kind of a very high-tech surgical instrument that we use. Similar to laparoscopic surgery, where we make little keyhole incisions, put instruments inside. In laparoscopic surgery, we're holding onto those instruments with our hands. In robotic surgery, we take those instruments, different types of instruments, but we have them docked in place on a surgical robot that's at the patient's bedside. Then Dr. Patron and I or our partners go over to a surgical console, where we look inside a viewfinder and get 3D imaging of what the camera is looking at inside the body. So it's a great technological advantage. There's lots of advantages to the robot in certain circumstances. It doesn't mean that a robot surgery is necessarily better than a laparoscopic surgery, but there are some advantages in certain circumstances where robotic surgery can be helpful. But like I said, we're in addition to looking, we're just not watching the robot do its work. We're working the instruments through some hand controls on the console.
Absolutely extraordinary. Thank you for explaining that. I can actually picture it now. It's really spectacular advances, but obviously you need the talents of an experienced surgeon and an experienced team, which brings me to the question of, can you talk a little bit about your collaboration as surgeons with the GI doctors and the larger care team? And then I'd also love to talk about, how does a patient end up with a surgeon and that process?
Sure. Well, I mean, it's kind of a stepwise fashion. Somebody gets referred to usually a gastroenterologist, and the gastroenterologist does a colonoscopy, finds something that might need surgical attention, and then they make their way to a surgeon. Well, how do they get there? Well, it's typically under the guidance of their doctors. Once somebody has you in their hands, they have the baton and they have to pass it along to the next person. And knowing who to pass it along to is an important choice for the referring provider. Either the gastroenterologist or the primary care doctor has a patient that they're taking care of, and they want that patient to be taken good care of. Just as when I send my kid to school, I want to make sure that they're going to get educated well and not get beat up on the playground. They don't want their patient to go and have a surgeon who isn't going to do the quality job that they would hope for their patient. So it's a lot about relationships and trust. The gastroenterologists and the primary care doctors have developed or are developing constantly relationships with surgeons and other providers. And after a while, they hear back from the patients. They say, "Oh my God, I had surgery with Dr. Foglia and everything went great. I was home after 2 days and everything was wonderful." And you see enough of those, and they say, "Geez, I'm going to start sending all my patients to Dr. Foglia." The other thing that's important is communication. We have a lot of communication within the care group that's taking care of patients. Just the people on this call. Between the surgeons and the gastroenterologist and the oncologist, well, there's lots of other people involved in the communication as well. There's radiologists, there's radiation oncologists in some settings. There's the primary care doctors, there's interventional radiologists. So these big groups of people all kind of have to communicate about the patients. And we actually have a forum that we participate 3 or 4 times a month regarding the care of cancer patients. We have tumor boards where different providers from different specialties get together and we discuss these patients. Every cancer patient, every GI cancer patient, colon cancer and rectal cancer patients that are diagnosed through our hospital or operated on at our hospital, we discuss their care and management. So those are kind of the key things is just the communication and the collaboration between the different people on the team.
I feel like a weight is lifted off my shoulders because I think that's, a big concern is that there are so many different moving parts to this. You want to make sure that you have a team in place that's collaborating. And it sounds like at, New York-Presbyterian Queens, there's that collaboration. I can't believe there's even, this meeting time where everyone gets together and talks about the patient. So thank you for sharing that. It really helps understand how the care is managed. Thank you. And thank you, Dr. Patron and Dr. Foglia, for helping us understand colorectal cancer. And obviously everyone's situation is different, and meeting with your surgeon directly will give you your personal answers. But please, if you have any questions, you can go ahead and ask them in the chat and we'll get to them shortly. Thank you so much, doctors. Now, when a patient is diagnosed with cancer, I'm going to talk to Dr. Hunn about what is next. Can you share with us a bit about the different treatment types that are available?
Sure. So Dr. Foglia already mentioned about the tumor boards that we're having to, discuss all the newly diagnosed colorectal cancers. That is very active, and we will discuss all the cases, and then we will plan out for the different treatment, because cancer care is a multidisciplinary team effort, really. And part of the team is actually one of our patients as well. So that's how we start the treatment planning. And then most of the times when cancer can be removed by surgery, it is considered to be curable, meaning that treatments are given for intention of eradicating cancer. So you might only need surgery, or depends on the staging assessment, you might need additional treatments such as chemotherapy plus minus radiation before or after surgery. And then for advanced cases such as metastatic or stage 4 or recurrent diseases after, cure diseases, because we're going to do the surveillance, then they're considered to be incurable in most of the times. So purpose of treatment in those cases will be controlling cancer to reduce the symptoms from cancer, such as bleeding, perforation, pain, or obstruction. And treatment modalities are chemotherapy, still for the lower staging cases, and when you need actually adjuvant, which means we're supporting the surgery and make sure that we're getting rid of the microscopic diseases that might be hiding in your body. Those are still chemotherapy. However, nowadays, as you are probably already aware, that we are coming to the precision oncology era, where we are doing the immunotherapy and targeted therapy, depends on the characteristics of the tumor as well. So some of the medications are infusion medications via intravenous route, or oral pills too. So we have the chemo pills, and also most of the targeted medications are actually pill forms. And also in selected cases with limited distance metastatic diseases, meaning that the original cancer going to another organs with 1 or 2 resectable, meaning that the surgery can be done, then it is considered to be still curable approach with the surgery with chemotherapy.
Very good. So there are a lot of different options, and based upon where how your cancer is, or your doctor your oncologist will assist you with that. Can you describe the collaboration with cancer support services, and talk a little bit about the benefit to collaboration with Weill Cornell, an academic medical center?
Absolutely. So we work for and closely with Weill Cornell Medicine. And our close collaboration becomes invaluable when it comes down to rather very complicated cases that ran through all the feasible treatment options, or certain techniques that we don't provide locally. So in cancer care, being able to enroll patients in clinical trials is one of the important aspects. There are ample clinical trial opportunities at Weill Cornell, and also we are very familiar with them, but also we do conduct our own selected trials at NYPQ. Also, there is a treatment modality, for example, hyperthermic intraperitoneal chemotherapy, which is also, in shortened term as HIPAC, which is done at the main campus as well. So let's say, we identify a patient who might benefit from that procedure, and we would refer to, the main campus. Once they get the procedure, and then the patient will continue to follow up with their own physicians in NYPQ. So there's very smooth transition in terms of, necessary procedures that might not be, necessarily provided at, local, hospital. Then we can actually send them and then, come back. So I would like to, note that we locally at NYP Queens also provide our own expertise in many areas of colorectal cancer patient care, as you are already aware.
I mean, it's really special that you can have access also to these trials.
Right.
Very often people have to search on their own for that, and to be able to have that collaboration where you're able to access these trials is something that's very valuable for the right patient.
Yes, correct.
Thank you for that. So you mentioned about recurrence. So if you could share with me a little bit about how can one minimize the risk of getting colorectal cancer to begin with, but also once they've had it and they've been treated, how can they prevent recurrence? Are there things that someone can do or eat, or what do you recommend?
So Dr. Gutkin already mentioned very thoroughly about, screening as one of the most important ways to decrease the risk of colorectal cancer. The reason is that biologically, I'm just going to repeat what she said because it's so important, that, colorectal cancer tends to arise from small polyps and takes years to grow. So, they allow early detection when you have the screening, and the treatment when it's easier to treat, that's possible. And also, I think it comes in hand in terms of, reducing the risk of getting colorectal cancer and preventing recurrence. So, good healthy diet, such as high fiber diet or avoiding charred food, is known to lower the risk of colorectal cancer. And also healthy lifestyle.
You say charred food?
Like the barbecue, with the burnt part of it, or very processed red meat, the ones that has the, nitrous chemicals and such. So those cases can be, avoided. And healthy lifestyle habits always help to reduce any cancer risks, such as quitting smoking, increase physical activities, controlling chronic disease that can lower your immune system, such as diabetes. So that would, yeah.
But as you said, screening is really critical. Even if you're eating healthy and you're not having charred food, which, wow, that's scary. I burn things up. But making sure that you're exercising, you're not smoking, but no matter what you're doing, make sure you get screened. And I appreciate your bringing that up again, and that I'm saying it again. It really is so critical because, as you said, it takes years to develop, which is not true of all cancers. Right. Not all cancers are as easy to be screened for and prevented. Correct. So thank you for that.
And sorry. Another thing is that, once you are cured, still we will do the surveillance after that. So that's another part that, it's going to continue.
So how often would someone, so let's say someone, had cancer, had treatment, how often, and I know that this varies, I'm sure, by patient, but typically how would you keep an eye on that patient?
So usually depends on the staging of the patient, what, they were the cure for. But at the beginning, we're going to see patients a little more often, every 3 to 6 months, and make sure that, there's no symptoms or, anything that can be worrisome for, recurrence of disease. And then if we feel that, it's necessary, we will repeat the scans as well. And then the interval is going to become a little more wider over time. When, from the diagnosis, it, gets, longer, then, we will increase the interval of the surveillance afterwards.
Okay, that makes a lot of sense. Thank you.
And also after the diagnosis and treatment, if things are curative, we go back in a year later to repeat the
To repeat what? I'm sorry, your voice
repeat the colonoscopy a year later.
Correct.
Okay, so after the treatment and the cancer is no longer present in your body, a year later, you're going to have another colonoscopy to ensure there aren't additional polyps.
And that's right, Elizabeth. It's to look for additional polyps. It's something that I quiz my residents on all the time. I say, why are we doing a colonoscopy a year later? And they say to look for recurrence, look for the cancer coming back. And it's not entirely true. It's mostly because if somebody has had a polyp that turned into a cancer, they're at risk of having more polyps that turn into cancers. So we're going to be a little bit more aggressive. It's the ultimate family history. It's, if their grandfather or their uncle had a cancer, that's, a relative. But if you had the cancer, you're at higher risk of getting another cancer. As long as you've got colon left, you can get more cancers. So it's important to kind of get those colonoscopies afterwards as well.
Is that more common with colon cancer, that you see recurrence, or not necessarily?
It's any other cancers also, but I would say colorectal cancer definitely, and breast cancer also.
Mhm.
As long as there's breast tissue left after there's surgery, there's a chance that you would probably have. So that could be sort of more organ specific in a way.
Yeah, and it's like I
That
said,
makes sense.
it's not so much necessarily recurrence as it is another one. You have a breast cancer on the left side that gets removed and treated, and you get a breast cancer on the other side. It's not usually a recurrent cancer, it's a new cancer that you have. Similarly in the colon. So just as in breast cancer, you undergo mammographies going forward, same thing with colonoscopies. But a little bit more specific, is recurrence common? The majority of the time when we find colon cancers early, they are curable. It's something I try to tell my patients at their first visit, because they're scared. They come in, they've just found out they have cancer. They're coming to see a surgeon. Most of the cancers that we see are curable. And sometimes it's surgery alone. Sometimes it's surgery with chemotherapy or targeted therapy afterwards, with adequate surveillance. But it's one of the great things about the jobs that all of us do here, is that we're taking care of these cancers that we can cure quite often.
That's fantastic. All the more reason to get screened, get screened, right?
Yes.
But what about, I wanted to just ask you a little bit about common health disparities, and what, if any, steps are being taken to address this?
So one of the reasons I chose to work in Queens is to address health disparity in our community. Socioeconomic stress, education level, racial disparity, language barriers, as well as cultural differences, you name it. All of them can really affect medical care and individual health in general. And we are overcoming this obstacles by understanding our community in a deeper level at NYPQ, and we are addressing our patients' needs through patient-centered care model here, and bringing more expertise to our own location, as well as keeping the close collaboration with Weill Cornell, as I previously mentioned. So you can just picture yourself, if you are one of the patients here. Basically, you have these many team of doctors, including gastroenterologists, colorectal surgeons, medical oncologists like me, radiation oncologist, radiologist, pathologist, genetic counselor, palliative care.
Wow.
Everyone is working for you together.
It's such an important thing. And I want to thank you for having this webinar today, because I think that's also a way to reach people, because sometimes people are embarrassed. Dr. Gutkin mentioned that also, like, don't be embarrassed, talk to your doctor. And having a forum like this where people can be encouraged to do so is really another great way to be able to help with that disparity and get the word out to so many individuals. You mentioned about the the patient-centered. Can you talk to that for a second, just what that means exactly? The patient-centered approach?
So it is, in a way, you can just sort of picture this, that, that most of the times when you think about, the healthcare and how you meet with doctors, you go to individual doctors with the referral and, consequent referrals, and you go there and go there. But, for cancer care specifically, it is very important that all the doctors who are taking care of you is on the same page. And, one of the biggest things that we can do, and we are doing, is the, tumor boards that, we discuss, because this is really multiple doctors' team effort to, make one thing happen, which is, eventually the goal of cure. So in those cases, we are working together for one individual case, looking at individual cases, as the most comprehensive way. So that's what I meant in terms of patient-centered cancer care model.
Thank you for being so specific about that, because I think that makes a really big difference. The idea that it's not just one doctor in a silo, but it's a collaboration of a team that's working to support the patient. And
we're all on the same page, literally. And so I would like to share an important point about disparities. Having health insurance is one of those important disparities. And something that I would like the community to know is that here at New York-Presbyterian Queens, we have a screening program through the navigators at the hospital that would allow a patient through New York State to get a screening colonoscopy, even if they do not have health insurance. So that's very important because that's one of the deterrents, and I would think a patient would think that there was no possibility, but here at New York-Presbyterian Queens, that possibility is there. We have a navigator program in place, and insurance or not, patients can get screened for very important things like colon cancer.
That's very important. That certainly is a way to alleviate disparities. And I'm actually going to share a phone number here in the chat. Because any Queens resident who's uninsured and meets the eligibility can call New York-Presbyterian CSP office. And I did share that phone number in the chat. I'll also share it in the email as well, so that in case anyone missed it in the chat, you can get it there. I'm also going to share here. Let me share it right here. If you want to connect with the team at New York-Presbyterian, I'm going to provide another phone number right here in the chat. Again, you'll also get it via email tomorrow as well, but you can connect with them at 718-670-2216. So you can go ahead and do that. Thank you so much, Dr. Hunn. That was really wonderful information. And I do have some questions from our attendees that I would love to pose to the doctors if you still have a bit of time to do that. Wonderful. Wonderful, wonderful. So we had a question of why would you get a stool test instead of a colonoscopy, and which is better?
So the colonoscopy is the visual test. The visual test is always better. The stool test is sensitive for human hemoglobin.
Mm-hmm.
So you are doing it because if a polyp would bleed or if a cancer would bleed, the FIT test would be positive. But not all polyps bleed and not all cancers bleed. So there could be some false negatives. That's why the colonoscopy, which is the visual test, would give you the entire picture.
Thank you very much for that. Joanne said, doesn't smoking increase the risk?
Yes, it does. Smoking does increase the risk. So it is one of the things that you can do for yourself to decrease your risk.
Terrific. So that's an easy one, although I'm not sure if it's easy, but it's important. It's certainly important. We have a question here about someone who, and again, I don't know if this is really an answer that you could give, but they want to know, why is our age assigned for different types of cancer screening? She has a friend whose son was diagnosed with colon cancer at only 35. So what can we do about that? Is that just an insurance thing? What should people, you said if there are symptoms, you should get them checked out. But I know that there are people that are concerned that maybe there aren't symptoms, and waiting till 45 might not be the right thing for them.
Sure. Well, sometimes that's why we say to always talk about the family history, and make sure first degree relatives, second degree relatives, is there a long history of cancers. And so then that individual would be not the average risk person, would be a higher risk person. In terms of where those age numbers came about as to when you start screening, based on multiple studies over the years and what kind of diagnoses were found in patients. You want to, when you put a recommendation forward as to an age for a certain screening for a certain type of cancer, you want to sort of cast the widest net. So you want to be able to pick up the most amount of patients in that age group to make your screening test a good test. And that's kind of how they come up with studies, based on those data.
So the data kind of drives it, but if you have a family incident or you have any concerns about what's going on with your body, that should override it.
Right.
Nancy wanted to know specifically if your grandparents have a history of colon cancer, at what age would you recommend someone like that go and start screening?
So we're always more concerned with first-degree relatives and multiple generational lines of cancers. Dr. Hyun mentioned that we have genetic counselors as well, that we often use to help risk stratify patients and uncover, genetic risk factors. So we don't account grandparents in that first line relative as putting the patient at a higher risk. If there are multiple family lines, that puts the patient at a higher risk. So I think it just needs more of a conversation. But, of course, if a patient is concerned, you have to talk about those concerns and provide them with the best tests that you have, to alleviate those concerns. Of course, with procedure-related things like colonoscopies, CT colonographies, things like that, this is where our offices come in and our support staff. We check with the insurance companies about, coverage for a specific exam. So you should never, kind of have these concerns alone. You should always address them to your doctor, and your doctor will work with your specific concerns and your specific family history and tailor the best type of exam for you.
Yeah, Ellen, and it's not perfect, and insurance companies do have something to do with it. And insurance company would not pay for a 25-year-old who has no family history and no symptoms to get a colonoscopy. And you could say, oh, those insurance companies, they're just looking for the money. But it's because if every 25-year-old got a colonoscopy, it would cost hundreds of millions of dollars to find a couple people with cancer. And then it becomes into philosophical discussion of how much money is it worth to do this. Well, colonoscopy is as safe as it is. It has a very low percentage of causing problems, but you always kind of have to balance the risk and the benefit of these things. So it is difficult. I think it's individualized. If there's a suspicion that there's a higher risk than normal, then we're a little bit more aggressive and doing these procedures on people who are younger than that age of 50 or 45. And in fact, as you mentioned before, Ellen, the age going from 50 to 45 is because we're seeing, now in 2021 and in recent years, that we're seeing more and more people in younger ages getting colon cancer. So that age is going down, and who knows, 10 years from now, we may be doing colonoscopies at everyone starting at the age of 40. So we're never going to catch that, that 22-year-old who's got a colon cancer that just, has a bad luck, problem. But we're trying to catch more and more.
We sometimes can, unless they have symptoms. So just to, again, underscore the fact that should you have any symptoms, please talk to your doctor. Don't ignore the symptoms. Don't think, well, I'm 20 or 30 or 40, there's nothing going on, it's something I ate, or if your symptoms are persistent and don't go away in a few days, please talk to a doctor so that they can direct you, because we've seen, this team has seen the 20, 30, and 40-year-old patient with the colon cancer.
Right. And I saw one of the questions in the chat was something about hemorrhoids. And I think a lot of the younger people who come in with colon cancers, they were having some bleeding, and their doctor said, oh, you're only 30 years old, it's probably just some hemorrhoids that you're seeing with the stool, and they have been treating them for hemorrhoids for a year or two because they think nothing much of it. And most of the time they're right. Most of the time it is just hemorrhoids in the 30-year-old that's causing a little bit of bleeding. But that's where you kind of jump in the line of this, well, you got to wait till age 45 or 50, and that person might end up getting a colonoscopy because of those symptoms, as Dr. Gutkin said.
Thank you. Yeah, there were a couple questions about hemorrhoids, and someone wanted to know what the difference was between a hemorrhoid and a polyp, and those are very different, right?
Yeah. Roger, why don't you chime in? Just a brief difference.
Yeah, of course. So yeah, a polyp is a degeneration of the normal lining of the colon or the rectum. Whereas hemorrhoids, we all have hemorrhoids. Hemorrhoids are vascular, are essentially veins that help and have a function with making a tight seal around the anus. They help with continence of gas and liquid. It's when they come inflamed that they occasionally bleed or cause pain, but they lie at the very, very bottom of the anal canal. And so, but they're completely different. Like I said, we all have hemorrhoids. And so it's important to determine when the bleeding is coming from an inflamed hemorrhoid, which is very common, like Dr. Foglia said, or is it coming from higher up, elsewhere in your colon? And that's what Dr. Gutkin is saying. Perhaps that's the type of patient that needs to have their colonoscopy done sooner to identify where this is coming from.
Can a hemorrhoid have cancer?
Technically, yes.
Short answer is no. It's like, everything, you can always see kind of these crazy things where there's this and that and the other thing all put together. The short answer is no, but that's not to detract from, if someone says, oh, I just have hemorrhoids, I've had hemorrhoids for 25 years, and now I'm just bleeding a little bit more. Well, it may be that, yeah, they have hemorrhoids for 25 years, but now they, in addition to the hemorrhoids, they also have a cancer. So it's something to keep an eye out for.
It sounds to me like you're better safe, get it checked, have a screening, and be sure, than make a guess and be wrong. Because it can be, as everyone has said, it can be prevented. Let me just ask one more question. I know that we're running out of time, and I do want to respect all of your time. How long typically do people have to wait for results, whether it be a stool test or a colonoscopy? Typically, how long does a test like that take to come back?
So the stool test comes back relatively quickly. It's something that is ordered by your physician, whether it's your primary care doctor or your gastroenterologist. The colonoscopy, the beauty of a colonoscopy is we see what's going on right then and there. So we know at the end of the colonoscopy, are there polyps or was it just the hemorrhoids? In terms of the biopsies, if you're going to remove polyps, that probably takes about 3 days or so. So these are not, up to a week, depending on special stains that need to be done, should there be anything sort of more worrisome. But this is not a very long time.
That's great. That's great. So people can go, get checked, get an answer, and be able to know what the next course is best for them. Thank you so much, Dr. Hunn, Dr. Gutkin, Dr. Patron, Dr. Foglia. I so appreciate your time. You really demystified colon cancer and helped us understand what we need to do to keep ourselves healthy and to address any issues that we have. I'm very grateful and so happy that you spent your time with us. And I want to thank all the attendees who joined us this afternoon to learn more. As I shared, this has been recorded. We will share the recording with you. Please share it with your family and friends. This is a great way to keep your family and friends healthy and prevent cancer, and also know what to do if cancer is a diagnosis. Thank you so much, and wish you all a wonderful afternoon. I wish you all to stay safe and stay healthy, and we'll see you on the next webinar.
Thank you very
Thanks,
much.
Elizabeth.
Thank you.
Thank you.
Bye-bye.
Bye all.